Hello, everyone. My name is Ryan Darvish, and I'm currently at PGY3 at Metro Health. And today we're going to be talking about a study that I've done titled Evaluation of 30-Day Complication Rates Following Vaginal Prolapse Repair with and Without Vaginal Mesh Implants in a Propensity Score Match Cohort. So just a little bit about why we did this study. Nearly half of Paris women will experience symptomatic pelvic organ prolapse, and 1 in 10 will seek out pelvic organ prolapse-related surgical intervention. One of the most common procedures done is anterior colporrhaphy, which may be utilized in up to 80% of pelvic reconstruction. And anterior colporrhaphy is often performed using native tissue repair techniques. However, tissue repair through mesh augmentation may be also performed, depending on patient and surgeon characteristics. And briefly, as you can see here on the left, a procedure being performed in the anterior compartment without mesh versus the same procedure being performed on the right-hand side with mesh implantation. A main drive for the use of vaginal mesh is the concern for failure of native tissue repair. A systematic review of reconstructive procedure outcomes revealed that approximately 29% of patients will require a repeat surgery within 4 years. Additional studies have demonstrated a benefit to mesh augmentation in the anterior compartment, with better subjective and objective improvement, as well as lower failure rates compared to native tissue repair. There is evidence that mesh-augmented repair is associated with increased morbidity compared to native tissue repair. While it would be expected that mesh-related complications would occur, some studies have suggested that perioperative complications such as infections and bleeding are more common in mesh-augmented surgeries. Aside from mesh-specific complications such as erosion, contraction, pain, and emotional stressors, there is little understanding of the incidence and type of adverse events surrounding surgery for pelvic organ prolapse when using vaginal mesh compared to native tissue repair. Our objective was to determine if mesh augmentation with anterior colporrhaphy is associated with higher complication rates compared to native tissue repair alone in a propensity score match cohort. As for the methods, this was a retrospective cohort study using data from the American College of Surgeons National Surgical Quality Improvement Program, NSQIP for short, from the years 2010 to 2017. CPT codes were used to identify women who underwent anterior colporrhaphy with mesh augmentation or anterior colporrhaphy alone. Demographic and clinical data were collected. Patients were excluded that had concurrent procedures in the posterior compartment, as we would be unable to know where the mesh was placed, or if they had diagnoses for rectocele or enterocele. Additionally, patients were excluded if they had a diagnosis of malignancy, had an abdominal procedure, or any concurrent non-gynecologic surgery. Given that there may be significant selection bias between patients undergoing mesh augmentation, we utilized propensity score matching for our analysis, matching women with and without mesh implantation at a ratio of 1 to 2. The primary outcome was the composite complication rate. Here are the results looking at the pre-op characteristics. A total of 16,020 women underwent at least one vaginal procedure for prolapse repair. Of these, 582 met all inclusion and exclusion criteria for anterior colporrhaphy with mesh augmentation. These cases were then matched by propensity score to non-graft augmentation at a ratio of 1 to 2. With respect to the graft-augmented group, 90.9% were Caucasian, the average age was 64.7, the average BMI was 28.6, and 6.5% were current smokers. Nearly 75% of these women had a medical comorbidity, with the most common being hypertension diagnosed in 52.4%. Diabetes was another significant contributor at 11.9%, and nearly 33% were American Society of Anesthesiology Class 3 or 4. As you can see, these values are similar in the non-graft augmented group. 91.3% were Caucasian, the average age being 63.8, the average BMI 28.3, with 7.3% being current smokers. Hypertension was once again the most common medical comorbidity seen in 50.6% of the patients, followed by diabetes in 9.7%. And similar to the graft augmented group, 28.8% were ASA class 3 or 4. All other parameters are similar between the two groups. As for our intraoperative characteristics, the groups did not differ. There was no difference seen in total operating time, vaginal hysterectomy, uterine weight, intra or extraperitoneal colpopexy, concurrent sling procedure, cystotomy, or wound class. Here we see the total complication rates. Patients who underwent mesh augmentation with interior colporrhaphy had similar rates of complication compared to those who had a non-augmented repair, 10.8% versus 8.6%. This was not statistically significant. No differences between groups for specific complications were seen, such as postoperative transfusion, superficial or deep organ infection, reoperation, readmission. The most common complication was urinary tract infection, seen in 5.3% of the graft augmented group and 3.5% of the non-augmented group, which once again was not statistically significant. Following multivariable logistic regression, mesh augmentation was not found to be associated with an increase in composite third-day complication rate. Dependent functional status was the strongest predictor of the likelihood of a complication. Other significant predictors were operative time greater than 120 minutes and ASA class greater than 2. We are able to demonstrate that there is no significant difference in non-mesh related perioperative morbidity, which is contrary to other studies which have demonstrated increased blood loss and infectious morbidity. This is significant as the population ages and increasing numbers of women undergo surgery for pelvic organ prolapse. It is therefore important to fully understand which patients may benefit from mesh augmentation at the time of surgery. We believe that this study is another data point that, when combined with appropriate patient selection and shared decision-making, can empower physicians and patients to determine the most appropriate surgical procedure, especially for patients who may not tolerate apical repair procedures and in whom native tissue repair alone would not be sufficient. In conclusion, in this large national propensity score matched cohort, we did not find that mesh-augmented interior colporrhaphy is associated with an increased rate of short-term, non-mesh-related complication compared to native tissue repair. These are the references, and thank you very much for your time.